In the SCN, things happen. In the pallidum, nothing happened except the dyskinesia are gone and partly the tremor, etc. In the VIM, the most boring target, very boring. Nothing happened. So SCN, things happen. And this, I think there's a bias.
Welcome to Stimulating Brains.
Hello and welcome back to Stimulating Brains. This episode is a conversation I had with Marwan Hariz, who is a legend in our field, who served for 16 years as the head of the stereotaxy surgery team at the UCL in London. In our field, Marwan is known for his way of critical thinking, of holding critical discourses, and for not shying away of pointing to flaws in studies. He is also known for using imaging and propagating the role of imaging in deep brain stimulation. And I really believe Marwan is someone who truly has something to tell. I listed most, if not all, papers Marwan refers to on the website. And there are also some nice pictures of Marwan taken by Harith Akram, who is also a surgeon at UCL, but also is a talented photographer. So check the website for these additional information. But now let's go. Right. So Marwan, thank you so much for doing this. And I'll briefly basically read from your paper, My 25 Stimulating Years with DBS and Parkinson's Disease, to introduce you a little bit. So you received your baccalaureate in Beirut in Lebanon. And then you studied medicine in Reims in France and in Umeå in Sweden. And you trained in neurosurgery in Umeå with Lauri Laitinen as main mentor. And then you received your PhD in 1990 in stereotactic neurosurgery. Had a great time, I think, in the field. And then you were recruited in 2002 as professor to the United Kingdom's first chair of functional neurosurgery at the National Hospital for Neurology and Neurosurgery and the University College of London Institute of Neurology, Queen Square. And there is basically, I think, where your legacy happened. And so the field knows you. You've been a big figure, a leading figure in this field. And I'm really honored to be able to interview you here in this podcast. So, but as mentioned, I would like to start with a non-scientific question. So could you share some light on the things you did when you did not practice medicine or science, maybe in London in your free time, if there was any? And then you retired from UCL in 2018 and moved back to Sweden, where you now. So how did your life and maybe work-life balance change after that?
In London, I was recruited in 2002. I started in October 2002, and I was fortunate to have Patricia Limousin as my main neurologist. And then the unit expanded and more and more people. But it was extremely important for me that it was the neurologist who wanted me to come there, and the neurosurgeon in general were against. The issue is because they felt threatened because there was no DBS or any functional neurosurgery at Queen Square because they were killing patients. And I'm not joking, I told them that. I'm here because you are killing patients here, or you were patients. And the whole DBS and pallidotomy was stopped 2 years before I came. And actually my first British patients were referred to Sweden. So the first British patient I operated in Sweden, and one of them referred by David Marsden.
Okay.
So it was quite tough to work against the neurosurgeon, and I was denied to do any other than functional neurosurgery. I couldn't be on call. I couldn't do tumors. I couldn't operate trauma, which I did in Sweden. I haven't done only DBS or pallidotomy. I was general neurosurgeon also.
Okay.
Anyway, so it happened that my free time, if I had free time in London, I went back to Sweden to my family because my family was, with the exception of 6 months, They were in IMU. And I was like what you call in Germany, a Gastarbeiter.
I see.
Which means I rented a very small flat and I only worked. So if I had to stay a weekend, I stayed in my office because it's better internet, etc., and worked there. And I was on call for my patients. So whatever happened with my patients, I was the one who took care of them.
Sure.
In the beginning, until Ludwig Zrinzo and others came. So basically, I think in my 16 years in London, I went to musicals, for example, 3 times.
Oh, wow. Okay.
And, I went on 2 days, 3 days vacation with my wife 2 times.
Okay.
So I was only working in London. And when I was not working in London, when I had free time, I went to Sweden.
I see. I didn't know that your life or like your family was in Sweden the whole time.
As I said, Gastarbeiter.
Yes, makes sense. So, how is your life now that you're back in Sweden? How is it going? Do you enjoy it more? Do you still practice clinically?
Well, I was fortunate because when I came back, I was already 65. That's why I retired. I had to retire from Queen Square.
Yeah.
But my old fellow, my previous fellow, Patrick Blomstedt, who you heard of him,
sure,
he asked me if I would like to work with him, or for him, or with him. And he employed me part-time, which means I work full-time, but I'm paid half-time.
Yeah.
And I don't complain because I have very free work. My work is mainly academic, writing paper, reviewing, mentoring PhD students,
nice.
Occasionally seeing patients, troubleshooting patients, operating now and then, not as much as before, of course.
Yeah.
And now with the pandemic, almost only battery changes or, emergencies.
Sure.
And I go to work 1 or 2 days a week now because I am a little ill or sick. But before I went to go work maybe 1-2 weeks, every 3 weeks or something like that. So I have much better life. I'm with my family. I do what I want. And very funny, normally an old student don't want to employ his mentor.
Yeah.
Mentor.
Yeah, it's understandable. Yeah, yeah.
Patrick was so nice and so self-confident. And he said, why don't you come and help me here? So he's my boss. So my old son is my boss. And we get along quite well. So I have a nice life. Not so much free time, but...
So amazing. A lot of work in life in work and dedication to medicine. I love that. And maybe then we can go into that directly. And so in 2017, modern day deep brain stimulation celebrated its 30th anniversary, and like you have been in the field almost all the way through, as can be read in this great paper, my 25 stimulating years with DBS and Parkinson's disease. And during that time, you've experienced, I would say, quite a bit. So could you shed some light on the beginnings of your career? Who were the mentors that stuck out? What were the crucial turning points? What were the experiences that you would say changed your career or made your career? Or that
I started with this in this field with Lauri Laitinen, and I was there with him, assisting him as his student for the first pallidotomy done in the modern era.
Yeah.
And as you know, during the 90s, the pallidotomy was very much published, very much recognized even by, or mainly by neurologists. Then DBS came in 1987, a paper from Grenoble on VIM DBS.
Yeah.
By that time, I was used to do thalamotomy for tremor, unilateral thalamotomy. What appealed with DBS is the possibility to do it bilateral in the thalamus. And but it would only treat tremor, not dyskinesia, not on-off, not all these things that pallidotomy could treat. So I had some experience in DBS before 87 because I did DBS for pain. deafferentation pain, phantom pain. I did few DBS in the VPM, ventroposteromedial, ventroposterolateral, centre median.
Yeah.
So I knew how to do DBS, but it was for pain. So when after Benabid published in '87, of course it was very much it was dramatic because you could see video on and off, and some of the video I pointed out to some colleagues. I won't mention them here. That this patient has rebound because he showed the patient like this
after and turning it off. Yeah.
And the patient was not like this before.
Yeah.
This was a rebound. Yeah. But it was not, they didn't say that during the meeting.
Sure.
So, and one of the first publication on DBS that I have was about tolerance and rebound following VIM DBS. That was the first thing because I have operated several patients in the VIM, and after a few months, a couple of years, so that when you switch off, some people could not switch off during night because they were shaking so much. And we introduced stimulation vacation, a period without. We even had to use in some patients Leponex, clozapine, in order to calm down the rebound, and also the tolerance that you have to increase and increase.
Sure.
Then STN DBS came, and my first patient of STN DBS is actually published, and it is a very much quoted case report, which is not usual to quote. Sure. It was a patient who the neurologist told me don't do pallidotomy because he's borderline in his cognition.
Yeah.
Let's do DBS. It's more safe. It's more It's okay. I did STN DBS. The patient had excellent motor response. We have video, we followed him, but then his cognition went down without recovering, non-reversible. So the patient's wife could tell me 1 year later that before I could leave him and go to work and then come back after a few hours. Now I don't dare to leave him because he opened the door, he go out, and then we have to ask the police to bring him back because he doesn't find his way home. So his mobility was excellent, but he was demented. Mm-hmm. And we published this in terms of did we improve the quality of life of this patient?
Yeah.
So, and then I went to visit Benabid, and by that time, Patricia Limousin had published her PhD thesis on STN DBS, which she mentioned in one sentence, if you have read it, just one sentence. One of our patients with the borderline cognition became demented after surgery. Yeah. And I said to Patricia, this is exactly my patient. But it was mentioned only en passant, just... So I visited Benabid, who I consider my mentor. And at that time, he used ventriculography, several X-rays, micro-recording. And the first side was finished at midnight. And Pierre Pollack was there at midnight. And I said to him, I've never seen a professor of neurology in the operating room at midnight.
Yeah.
That was for the first side.
That was the excitement in these times, right? I would guess. Yeah. So
Benabid is, so to speak, my mentor. Although I don't use Ben Gunn and Mac recording, but the courage he had to target the subthalamic nucleus, which was, remember, no man's land in stereotactic surgery.
Because of the hemibalism fear, right?
Which eventually has been put into doubt by Obeso and Guridi in a paper that maybe the Parkinson patient don't get hemibalism.
Yeah.
Anyway, so that was my and then we jumped to STN DBS, and I did a lot. And the first paper showing that if the battery fails, the patient gets a rebound of symptoms that do not respond to L-DOPA. That was the first paper on STN DBS that I published. And I reminded Professor Deutschel when he wrote his paper about the same thing that he should have mentioned, because that was the first time I noticed that we with STN DBS have transformed a slowly progressive disease into an emergency condition in some patients, as you know.
Yeah.
I have changed battery at midnight in London, either for dystonic storm, rebound, or for STN DBS
Yeah.
So, but still, it is so far, despite all the gene therapy and cell therapy and all these therapy, the best therapy, surgical therapy for treatment of the symptoms of Parkinson's disease. The problem with DBS is that, of the STN, is that you have a much narrow inclusion criteria.
Yeah.
While in thalamotomy or palidotomy, you didn't care so much about age or depression or
Sure.
But now the ideal patient for STN DBS is somebody who basically does not exist.
Yeah, with no cognitive side effects, no psychiatric side effects, and so on and so forth, right? Young age, optimally.
Good support, young, good brain, good,
Yes.
too short disease duration, good L-DOPA response.
Sure.
How many
They don't
patients?
exist. Yeah. So
And that, by the way, that is one of the things that have triggered interest in other things around Parkinson. When some patients, in the beginning, they get crazy or they get disinhibited or hypersexual or psychotic or this or that. There are a lot of publications, and this triggered, in a way, interest of psychiatrists and other scientists into this STN and its limbic part and associative part, and we're still looking for the so-called sweet spot that you, with your work, try to.
We try, as many.
And I'm still saying, and my experience show me that some patient you have the electrode extremely well placed, anatomically extremely well, but it's not working, or the patient get crazy. And I used to say to Lozano and others that there are no firewalls in the STN between associative and limbic, etc. And I challenge any neurologist to show me a single patient who is a little bit crazy, a little bit behavioral, changed, but who is not at the same time very good motor-wise.
Yeah, true. That's a good point.
Show me an apathetic patient who cannot move and still, speed it up. You understand what I mean?
Yeah.
So how come my patient who get a little bit strange are very, moving and running and very good motor-wise?
So you're saying it cannot be just a limbic network effect, but there is a motor effect. So we see that, and then these patients sometimes, in addition, also get, and only some of them, get cognitive or psychiatric side effects. That's what you're saying, right? Yeah,
I'm saying that there are patients who have very good motor effect, but who have apathy or depression or this or that, or hypodopaminergic behavior, like Paul Crack will say.
So going in the same. Sorry.
But I have never seen a patient who becomes between quotes crazy, in his behavior, who is not also very good motor-wise.
Yeah. So going in the same direction, you mentioned once, I think via email, that STN DBS is 100% psychosurgery. I'm wondering, why is that? I would guess because it's connected to the whole prefrontal cortex. The small structure is really receiving input from the whole prefrontal cortex. Do you think that is the reason why?
I think so. This nucleus is a very connected to many parts, and you have shown that in your. Come on, you know better than me. I'll tell you, if you read the literature, the first 2 cases of OCD getting better with STN DBS were from Salpêtrière in France with Luc Mallet. Yeah. Where are these electrodes? They are anteromedial. By the way, I told the surgeon at that time, how come you ended up there with 5 micro recording to pinpoint the sensory motor part, and your electrodes are 0.5 centimeter anteromedial, right?
Sure. I know what you're hinting at, yeah.
So this was the first. And then the third case was from Denis Fontaine in Nice with the same thing. And then everybody moved to do, including me, to do STN DBS for OCD.
Yeah.
And I think there are no firewalls, number one. Number two, I think that this nucleus with its projection everywhere, especially to the frontal, has triggered the interest of scientists, psychologists, psychiatrists, neurologists, etc., in this nucleus. Nobody cared about tremor and the wind. Nobody cared almost about the palindrome. But the STN is now, if you go on PubMed, most of the publications are about STN DBS. Yeah. And we still don't know exactly what this thing does, and we still don't know exactly where to put the electrode, despite all the tractography and Hariz and you and all this.
I agree.
So it will continue to generate a lot of papers, a lot of research. This nucleus. But I must say one thing that is important to say. The first multi-center study published in September 2001, on the basis of which FDA approved STN and GPI-DBS.
That was the New England Journal paper, right?
A scandal. Because in the table number 3 in that paper showed that you have 1 dysarthria in 102 bilateral STN-DBS.
Yeah, it's unrealistic. I agree. Yeah.
And you have 0 dysarthria in 42 bilateral palindrome DBS. So I wrote a letter to the New England Journal.
Yeah.
That's my only publication with my name first in the New England Journal. I have no other publication. Saying, what is this? How come only 1 dysarthria? Remember, that was 2001.
Yeah.
What we know today and since 10 and 15 years is that dysarthria is the main side effect of bilateral DBS. So how come a bunch of neurologists with Olanov and Obeso and others, and you can quote me because I told them, this is fraud. Not only that, I forced Medtronic to give me the database, the database on which, and I can send it to you by email later if you want to show it.
Yeah.
The database on which the paper is based show at least 18% dysarthria. And not only dysarthria, the whole table of side effects of the New England Journal paper from 2001 had almost no side effect. And in the database, you have much more hemorrhage and strokes and infection and everything. So it was a fraud.
That is amazing. Yeah,
absolutely. I can send you the database of the paper, and you can see yourself. It's called it's named confidential database. It's no longer confidential because I threatened Medtronic said we have nothing to do with that. We just put the figures there and gave it to the neurologist to write the paper, but they neglected that. And then when Steve, what's his name, Chris Gutz, Gutz, the from Chicago, who was the head of the Movement Disorder Society, he wrote a paper that the neurosurgeon neglect side effect. The neurosurgeon didn't care about side effect. So I sent him an email with that paper, among others. Mm-hmm. Those who neglect side effect are not the neurosurgeon. It's the neurologists for their agenda. And I have the email. I can send you this email also to him. And I said, please be careful what you write. We neurosurgeons, we are scared of side effect.
Yeah, sure. Yeah.
Some neurologists don't care about side effects. And it's a fraud. This paper is fraud.
I really honestly don't know what to say to this. It's very important to because this is what everything is based on, right? This is what the FDA approval is based on, if I'm not mistaken, and the CE mark probably. So that should be. I mean, yeah, it's probably too late to have a consequence now, but it's good to uncover that. Yeah,
that the main author became the editor of Movement Disorder Journal.
Sure.
It's politics.
Before we go into the more modern time, I would love to pick your brain a little bit about, especially that era, a bit before that when, DBS was still so hot and new. I mean, it's still an amazing technique, but you once mentioned that you were headhunted to Queen Square, which is the mecca of neurology, and by the neurologists, as you just said. And then you introduced also DBS in New York City when you were visiting professor at the Cornell, apparently twice, and then also to other university hospitals like Cape Town, Northern Norway, and so on. So we as young people, we always talk about how these times must have been like. I still feel that also the quality in data acquisition and everything was better because people were so dedicated to make this work and to work together and to, even the imaging was sometimes better, as you have shown me as well. And because people had something to lose, I guess, and also because there was so much excitement. So how did that feel like, or how was your experience with that?
I think at the beginning, people visited each other much more.
Okay.
It was not many people who did that. So I visited Ben Abid, although I have done DBS, as I said, I have done many pallidotomies, and if you can do a lesion, you can put an electrode too. Yeah. But I visited Ben Abid to really learn his thinking, and spent 2 days there, and then I had colleagues who called me. At that time, we were not so many. One of them was one of the first colleagues who visited me in Umeå. Now I'm talking before Queen Square in Umeå. Yeah. Was a famous neurologist from Holland, Johannes Speelman. Have you heard of him? Hans Speelman.
I have not. No.
Well, Hans Speelman wrote a thesis. His mentor was Jan van Manen. Mm-hmm. Jan van Manen is the father of Dutch functional neurosurgery.
Okay.
He was a neurologist who trained to do stereotactic surgery, who did his own frame. He had his own stereotactic frame. He's still alive, by the way. You can Google him on PubMed. And his pupil was neurologist Hans Speelman, who helped Andries Bosch and Rick Schurman, in Amsterdam, to do, and he was in the operating room all the time. Now, Hans Speelman, who I didn't know, wrote to me and came up to Umeå. And I was very happy, of course. Somebody big like you, why do you come to see me? Why didn't you go see Leitinen, who was working at that time in a private hospital doing pallidotomies? And he said, if I go to Leitinen, I see the glamour. If I come to you, I will see the reality. So Hans Speelman, by the way, has a thesis on thalamotomy.
Okay.
With a mean follow-up of 19 years.
Amazing.
Show me a paper today with 19 years follow-up of STN or whatever. Now, Hans Speelman is Google him too, has published a lot about. So the first who visited me was a neurologist. And then other colleagues visited from Japan, from UCLA, from other places. And the funny thing is that in the United States, this became something that the hospital could make money. So there is a guy who visited me, I didn't know him, and when he came to the operating room and we started to operate, at that time I was using the Leitinen frame, and I asked him, what frame do you have? He said, I don't have a frame. Okay. I said, well, wait a minute, are you coming to learn pallidotomy and DBS and you don't have a frame? He said, no, I am spinal surgeon, but my hospital want to make money on this, so they send me to somewhere to learn.
Wow.
Can you imagine? That's United States.
I can partly imagine that, yeah.
So, and instead of staying 2 weeks in northern Sweden, he stayed 1 week, and then the second week he rented a car and did a tour in the country.
Okay.
And then he wanted to have a paper that has been trained by me for 2. Anyway. And then I was invited as a visiting professor at Cornell. It happened at the time when the FDA had the New York State had just approved DBS for VIM. Yeah. VIM. And the hospital affiliated with Cornell wanted to be first.
Makes sense.
And the surgeon, I knew the surgeon, he knew how to do thalamotomy and pallidotomy, but he wanted to have instruction on DBS. And I cannot touch the patient. I don't have license. So I was only,
at the screws or at the frame.
No, not the frame was, he did the frame, everything, but I was testing the patient during surgery with the external stimulator.
Ah, okay. Yeah.
Well, you test with external stimulator.
Yeah. That's what I do usually.
Yes, exactly. So he operated 2 patients and it was published in the newsletter, etc. So that was it. And then it was South Africa, Norway, Enschede in Holland, other places where I was very happy to go because I knew this surgeon. There were people I knew, friends, and I stayed in the home of, and I never had money for that. I mean, I didn't ask and was not. They paid my trip and my hotel, or I stayed in the home of the surgeon. But it was very nice because I could see other places how they do, and exchange idea. So at that time, we were not so many, so it was very much personal. And it was not, Andy, it was not for research. It's not like you go to MIT and you do research. It was just visiting for 2-3 days in a hospital for a clinical work. And what I did then in all these visits, I started to evaluate imaging of the STN in all these places. And I published that paper with Paul Crack and the guy from South Africa and other places, where I went to all these places and published this paper about quick pre- and post-operative MRI.
Okay.
From that long time, 2002, I think. And all these places I've been, we tested our sequence on Philips, on General Electric, on Siemens machines, and could come up with the paper. And each patient did immediate post-operative MRI before Medtronic had its guidelines. Or
That's amazing that it started so early to do MRI afterwards directly. Yeah.
And you saw, I think you saw that paper with many names there.
Yeah.
Uppsala, Kiel, South Africa, Trondheim in Norway, Nara in Japan, etc. And that's it. Because my philosophy, and this is very important as an old neurosurgeon like me, because when I trained, it was just the CT scan. And in functional neurosurgery, when I started there, it was ventriculography.
Yeah, sure. Yeah.
And Laurie Leiter said, now we have an MRI that came, that you can use as much as possible with several sequences, with not only axial, coronal, and oblique, and try to see what you want to see. So I was very much concentrated on structural imaging. There was no fMRI at that time, no tractography. Structural imaging. To see what you want to see and to see after. Like you go to a pub in London and you use dart, right? You know dart?
Yeah.
So you don't throw the dart and go home.
Sure.
Just throw the dart and you go and see if you have in the middle of the...
Of course. Yeah. That is something, to close the loop again as a surgeon, I think that's really important. If not, you have no potential to improve, right? If you don't see that.
Okay. Yeah. I mean, despite MRI, despite micro-recording, like Jerry Vitek, a good friend, you know Jerry Vitek?
Sure.
He just published a paper now about the Boston Scientific electrode. Okay. So Jerry said to me, I know where I am because I have the micro-recording. I said, no, Jerry, you know where your micro-recording electrode is.
But then you pull it out and then you put...
It doesn't tell you where your DBS will end up.
Agreed.
And we have many examples of that in the literature.
Sure, yeah.
Of this place. So despite micro-recording, you have to do an MRI exactly like the previous one, with thin slices, with the same sequence, to see where you hit it.
That leads me to my next point that I think we should not, or we cannot avoid somehow, and we should not avoid, because that is really what you stand for. There are a lot of things you stand for, but for example, I think you are really an expert about also the historical developments of our field and so on. But I guess one thing that is the most particular that you stand for is really the strength of imaging in functional surgery. And you've pioneered this, like as we just talked about, in very early time on 1 Tesla MRI, you were able to, as you showed me, see the lamina interna of the pallidum and so on. So that is amazing. And also you stand for not liking microelectrode recordings.
There is a misunderstanding here. People perceive me at meetings that I am against micro-recording. I am not against micro-recording. I swear. I went to Benabit to see micro-recording. I went to other places, to Schurman, to many places to learn micro-recording.
Yeah.
Problem is the following. My philosophy, and I have family who has Parkinson's disease and operated. I have a cousin who had juvenile Parkinson's operated in Lebanon. I prefer a patient going out from the operation room exactly like he went in.
Yeah.
Sorry, we could not help. You go back to your medication. No harm done.
Yeah.
But I cannot stand a situation where the patient goes out from the operating room with well-placed pallidotomy or electrode, with fantastic, but a big hemorrhage somewhere.
Sure.
So I tell all my patients, if we can help, that's good. If we cannot help, you go back like you were before. And in my career so far of over thousands of all kind of capsulotomy, cingulotomy, everything.
Sure.
Zero mortality. I touch wood now.
Yeah.
I touch
Yeah.
Zero paralysis. Zero. But I have stopped surgery during surgery in few patients where I couldn't find the target, or there was something, or too much air, or something. I tell the patient, sorry, I don't continue. I remove the electrode, I close the wound, and go to duodopa or apomorphine or anything else. And these were usually in patients who were old with too much atrophy, where we tried to operate anyway. So for me, micro-recording, if you ask anybody, even Lozano has published that with several micro-recording tracks, you have 5 times more risk of complication than without micro-recording.
Yeah, okay.
A publication from Harvard on 81 pallidotomy, zero hemorrhage, and the same surgeon, 2 years later, DBS with 2.5% hemorrhage. Yeah. What's changed? Pallidotomy, a lesion, zero hemorrhage, and DBS 2.5%. He was using micro-recording. Mm-hmm. So for me, and Leitinen too told me, micro-recording is a very important research tool.
Yeah.
You have to consent the patient that you want to study, I don't know, how the neuron reacts to whatever. Yeah. And you do it on a limited number of patients, and you have your conclusion. The same way as you do your tractography on a limited number of patients, and then you do your... And not only that, I praise and I have published that some of the most beautiful papers I have seen were using micro-recording to showing something. I'll tell you one by Lozano and his team, where they gave apomorphine during surgery to the patient without the patient knowing. Okay. So they were recording the neuron, so the activity, the hyperactivity, and the pattern, and then the patient got apomorphine during surgery. Okay. And before the patient started to turn dyskinetic, there was a complete decrease of the pathological activity in the. This is beautiful. I can't do this. This is fantastic, right? Yeah. So this is a paper on few patients showing the behavior of the neuron in off situation and when the patient gets apomorphine. I have nothing against that. But what I have against is the dilettante, the fundamentalist, the Al-Qaeda of micro-recording, who say, if you don't do micro-recording, you cannot operate.
Sure.
You understand? And not only that, when focused ultrasound came, when focused ultrasound arrived, those who were most enthusiastic on focused ultrasound were people who said, you cannot do any surgery on the basal ganglia without micro-recording.
Yes.
My question in public to Lozano at the MDS meeting in Berlin in 4 years ago. You remember there were MDS movement meeting, and Lozano was talking, and there were hundreds of people, and there were questions. So I went to the microphone. I said, "Now you showed your fantastic focused ultrasound on the thalamus. What did the micro-recording show?"
That's funny. Yeah. I mean. I would have asked, because I guess MR guided focused ultrasound will lead us to more imaging, because people are already in the scanner, so we can potentially use all these fancy techniques and individualized targets maybe in the distant future, and then use that, and so imaging will become stronger. I perceive it has already become stronger. So yeah, I agree with you that imaging is definitely a future avenue for our field and has always been. So
sorry to finish about micro-recordings. I'm not against micro-recording. I'm against the fundamentalists in micro-recording, and I like and love and read a lot of micro-recording papers where you learn something from the behavior of a neuron, whether it is in the anterior cingulum or STN or pallidum or whatever.
Yeah.
So this is a scientific tool. But as you know, in the United States, there is a company called Micro-Recording R Us, like Toys R Us.
Yeah. Okay.
They go to some hospital and the surgeon doesn't know what he's doing, and the neurologist has no idea, and they say, this is the target, and then they charge the hospital and they go. Okay. And another thing that in the US, it's question of money.
Sure.
They charge more to have micro-recording. Hospital
Okay. I didn't know that. Yeah. Okay. So they outsource that as a service. Yeah. Okay.
Some hospitals they outsource because neither neurologist nor neurosurgeon understand the microrecording.
Okay.
And speaking of imaging, Andy, the main advance in neurosurgery over the last century is imaging. Is the ability to see into the brain of a living person.
Yeah.
Before the old literature about thalamotomy, you had to have autopsy. You know, people like Traugott Richert in Mundinger, Hassler, they have books about pathology. I mean, you know, the autopsy of patients to see where the lesions are. Now you have CT and then especially MRI, where you can see in the living brain what you have done.
You directly see it. You don't have to wait 20 years for that, right?
And also you have an infinity of sequences today in the MRI where you can try. I tell my physicists, I want to see the white matter in the pallidum, the lamina.
Yeah.
Find me something. That's how it started. 2 weeks later, I found something. And it was the proton density that we published in 2001 on 1 Tesla. You remember that?
Yeah.
The same with the STN. The funny thing with focused ultrasound is that they chose the only target that you cannot see.
the thalamus. Yeah, interesting. Yeah,
the only target that the one you cannot see. Yeah. And now Jose Obeso is a nice guy.
Yeah.
He published about focused ultrasound of the STN that you can see.
Yeah, sure.
You know, the papers about. So imaging, I think, is the future, especially now with people like you and Hariz and the functional imaging people who are. I mean, I am no longer following so much. I don't understand these things anymore.
So I could not agree more with you, as I just mentioned, but just to play the devil's advocate for a little bit, I sometimes think that, you know, such as TV killed the radio star. I sometimes think that MRI killed the anatomy star. So, you know, of course, MRI is great and it's in the living brain. That's amazing. But if you compare it to histology, we see not so much, right? So sometimes I even feel that our field loses the anatomical details because anatomy was not on the rise for a while. And the need for more precision, or to really, of course, with advanced imaging, we are slowly getting to better resolution. But what's your thoughts about, you know, us becoming a bit more ignorant, maybe because we don't see all these small structures anymore?
Oh, it's not only that, Andy. The problem is that people look, but they don't know what they see, what they look at. They don't know what they see. Even in structure imaging. I can send you a paper from Beth Israel, Harvard.
Yeah.
Harvard.
Yes.
Put the substantia nigra compacta at the level of the third ventricle. This paper, they say electrodes in the substantia nigra pars compacta. And the image they show is at the level of the ventricle.
Okay.
Axial image at the level of the ventricle.
That can be, yeah.
Because, and I said to myself, the nigra compacta is 1 kilometer below the ventricle, you know, in stereotactic space.
Yeah.
You know, it's you have the reticulata and you have the compacta even more medial and inferior.
Yeah.
And these radiologists from Harvard say this is the electrode in the substantia nigra pars compacta. There is another example where continuing medical education, I will send you that too. Mm-hmm. Continuing medical education from Mount Sinai Hospital in New York. I paid $50 to learn that the GPE and GPI are separated by the internal capsule.
Okay.
Have you seen it?
I haven't seen that one. But in fact, I have seen the reverse case very often, that people say something is the STN while it's probably the nigra, because it's the ARCA, it's more easy to see. So a lot of mislabelings happen also in that direction. I agree. Yeah. This can be difficult to differentiate both, of course, at some level. Yeah.
But the head of functional stereotactic surgery at Mount Sinai in New York, giving a course where you pay $50, saying that GPE and GPI are separated by the internal capsule. This is still online. This is still on. You can go online and still see that. So people are dilettante parvenus. You know what parvenu and dilettante. And they are sometimes in high position, especially in the United States, I'm sorry to say.
Okay.
As you know.
I mean, I've talked with Christian Moll, and I really think in these early days that you just mentioned with Hassler and Mundinger and so on, we came to the conclusion that, you had to collaborate with an anatomist to make this work at these times. And now maybe everybody can do it because we think we see the structures on the MRI, but that really, in my view as well, is also a danger because...
No, what they haven't studied the Atlas of Schaltenbrand in detail. They haven't studied radiology in detail. Yeah. They haven't used... That's why I told you once that the basis of all the imaging is structural imaging. Yeah. You have to have the structural imaging to have a seed somewhere to see your tractography, whether deterministic or probabilistic is another story. I have seen fMRI papers where they put, for example, something in the PPN and it's in the cerebellum. Published. So I think that the basis is anatomy, which you can see on structural imaging of MRI and or in the books also, and in the laboratory on autopsy. But the other thing also is that this multidisciplinarity of anatomy, etc. I mean, everybody say today you have to be multidisciplinary. I say, wait a minute. The whole field started by multidisciplinarity.
Sure.
It was Ernst Spiegel, neurologist, and Henry Weiss's neurosurgeon. And then you have on the first paper, Mark, who was a physicist. The first paper of Spiegel and Weiss. Multidisciplinarity was from the very beginning.
Yeah,
and the two neurosurgeons who were cowboy, they were cowboy because you have neurologists who were cowboy too, Yeah. And in some cases it was difficult to get at certain people to get the neurologist in the operating room because the neurologist didn't want to hear about operation. It's a little bit like psychosurgery, where they say the old neurosurgeon were doing lobotomy. Wrong. Those who were promoting lobotomy and sometimes doing were psychiatrists. Mm-hmm. If you look at the list of what's his name? Walter Freeman was a neuropsychiatrist, the founder of the American Neuropsychiatric Association. He was a neurologist or neuropsychiatrist who learned in Italy how to do the transorbital, and he learned that from another psychiatrist in Italy called Fiamberti.
Okay.
I have a whole lecture about that. Most of the people who did lobotomy or promoted lobotomy were psychiatrists.
Okay.
So don't blame neurosurgeon for neglecting side effect, not being multidisciplinary, doing lobotomy and...
I mean, point is well taken. So going back to exactly that, in 2019 you received the highest award of the World Society for Stereotactic and Functional Neurosurgery, which is the Spiegel and Weiss's award, right, named after these pioneers, Ernest Spiegel and Henry Weiss, that you just mentioned, and they introduced stereotactic surgery in a landmark paper in Science in 1947. And they worked in Philadelphia. So we already, as mentioned, learned from Christian Moll in the first episode here that they also published the first stereotactic atlas for surgeries in humans. And they further described basically a Horsley-Clark apparatus, which is a stereotactic frame that relied on internal cerebral landmarks, which made it accurate enough to be used in humans. And that time, the fields in human neurophysiology were really pneumoencephalography, radiology, and so on. They had it advanced enough to provide the first time the required technology. But as you mentioned, maybe you had to be a cowboy at that time. And I have two questions. So first, how does technology shape our field, like back then? And then what can we still learn from these times? Or do you still, would you say it's good to look back and to learn from these pioneers?
If you read the literature, the best papers were published in the 50s and 60s.
Okay.
Long paper, detailed. There are conferences also. I can send you a conference where it was published verbatim, you make a talk and I'm in the public, I say something, it's published.
Yeah.
This debate was fantastic, and to read this detailed paper was fantastic. Now, when it comes to technology, I mean, the XYZ before CT scan were different. You remember? There was X like this, Y and Z was the lateral.
Okay.
When CT scan came, before it was side view and frontal view.
Yeah.
Ventriculography.
Yeah.
Then came something which is axial.
Okay.
It changed the whole coordinates were changed. So X was like this, Y is anterior, posterior, and Z. And we started to look at the brain in a different manner than we looked before when you had only ventriculography.
Makes sense.
And everybody had to reshape their frame so they are CT compatible.
Uh-huh.
The frames, if you look at the first Richard Mundinger frame, and now it's the Zamorano di Giovni, the old Leiten, the new Leiten, the old Lexel, the new Lexel, the DRW, CRW, even Sugita in Japan had the technology, the imaging forced people to name the few new coordinates another way, to do frames another way, so it is compatible.
Yeah.
Then came MRI. Same thing. I mean, the impact of imaging, Andy, is much, much more than you think.
I can imagine that, yeah.
MRI compatible frames. You have completely new design, new alloy, and new way of targeting the coordinates, or calculating the coordinates. So technology, it's like Karl Marx say, it's a dialectic between what the surgeon and neurologist want and the technology, and they influence each other, and this what brings the field forward. Then micro recording, it was semi-micro recording, and I'll tell you a story that you don't know.
Sure.
Denise Albefessar was the mother of micro recording. Mm-hmm. Semi-micro recording. She worked in fish and then in monkeys, and then she worked with Gérard Guillot in Hôpital Foch in Paris. And she is the mother of micro recording. Her first publication was in 1961 or 62.
Okay.
About micro recording of the VIM. And at that time, the Guillot frame was from posterior to anterior. You enter the occipital lobe, and you traverse the pulvinar, the sensory thalamus.
Really?
Yes. I'll send you. I make a note here. Guillot.
Thank you.
So you go from you see me?
Yeah,
I
do.
You go from here. So when you go from here, he could do a thalamo-pallidotomy, because you go with your electrode, you go to the pulvinar,
Yep.
and then the sensory thalamus, and then the motor thalamus, and you exit the capsule internal capsule, and you continue, you are in the pallido.
You go through the thalamus from basically the occipital lobe through the thalamus to the pallido? Okay.
She did micro recording of all these things, and she could delineate the VIM. The VIM is her discovery, not Hassler. Hassler didn't talk about VIM. So Denise Albefessar was working with Guillot for many years, until one day Guillot told her, please, we cannot work together anymore. And this is a story I got from somebody who was there, whose name is Fardo, who was a neurologist there, and he's now 80 years old in Paris. And he told me, no, they divorced. I said, why? He said, because at some point, Guillot told her, Madame, le cerveau n'est pas une passoire. Madame, the brain is not a sieve.
Ah, sieve. Yeah, okay. yeah. So it's not to be punctured by electron. Okay.
The neurosurgeon told the physiologist, the brain is not a sieve.
Mm-hmm.
Sieve, how you say in German? Sieve, right?
Yeah, sieve in German, yeah. So, yeah. Wow.
So, that was a story that is not published. And that's why they finished their so to go back, it is imaging and the technology, especially imaging, is driving. I mean, today, Lozano does DBS in the hypothalamus for obesity.
Yeah.
The patients start to have flashbacks.
Yes.
Lozano go and look at the MRI. Where the hell are the electrodes? They are at the fornix.
Yeah.
Right?
Yeah, sure. Yeah, I know the story. Yeah.
Oh. Maber and Lozano discover a new target thanks to PET, which is also imaging.
And fMRI. Yeah, imaging. Yeah.
First paper was in PET. The first paper was PET.
Yeah.
I know the literature, Andy, in detail.
No, I know that. I just think the multimodality was kind of cool in that story. But of course, Helen started with PET, so yeah.
And what Helen didn't say, and nobody said, is that target was used by Lorelei Tennant to do cingulotomy.
Oh, was it?
And we have published a patient who had cingulotomy in Finland 40 years ago. We found a patient who was still alive, and we did an MRI of that patient to show that was his target, and the lesion is exactly in the Maber area. I'll send you the paper.
Great, that would be amazing. I can put a list on the website. Yeah.
I can send you the paper because Leiter had published 2 papers about his rostral inferior subgenual cingulotomy. But that was ventriculography. Nobody knows where the lesion was.
Sure.
So I told my colleague in Finland recently, just 2-3 years ago, can you find a patient who had cingulotomy in the 60s or 70s who is still alive? Yeah. They found 2. Okay. One refused to do MRI, and the second did MRI, and they had the interview and the checker. And her lesion is exactly where Maber Lozano is.
And that was for depression or for psychiatric? For OCD. Okay.
I'll send you the paper.
Amazing. That's very exciting. Yeah. So I mean, this again, everything you say always leads me to the next question that I wanted to ask. So in our field, you're also known as the arbiter of truth, and I think you don't easily let go if people publish false results, and you sometimes, I think, have given entire talks about published pearls or mistakes in studies, and I've also authored countless response letters to studies together with others. And you've mentioned Andres Lozano, and apparently he used to call you the stereotaxy police once, and this was an honor to you mentioned. And another time he called you the court jester, which you told me was also horrific, since the court jester was the only one who could speak the truth at the court of the king without being hanged by the king. So you once mentioned to me that maybe the only thing or something that you really don't like is sloppiness and arrogance. And personally, I really think we need such a person in our field. So we need the court jester, and we need the stereotaxy police to detect false concepts. And we should do that more. So also others. And even if it's just to get discussion started, because critics aren't always right, of course. But I really think your role will be dearly missed. And I think most people think so, in case you ever retire entirely. So would you like to share some thoughts about this? What was it for you?
For me, it's actually, we are doctors, right? You are a doctor. Yeah. I mean, you are scientists also, but at the end of the day, you owe to your patients the truth, right? So if your patient has seen a paper on not PubMed, on Google, yeah, and come and tell you, look what happened, and why I'm like this, and you tell this patient, this is a fraud paper. And this happened to me. My first patient who got severe dysarthria and dementia eventually, that I told you, yeah, my neurologist at UMU came to me and say, Marwan, how come we have so much dysarthria? Because it was the first patient and then another patient, not all the patients, but yeah, look at this paper from the New England Journal. They have only 1 dysarthria in 102 patients.
Mm-hmm. Yeah.
My neurologist is telling me that I have more dysarthria than 102 patients who had only 1 dysarthria. Mm-hmm. I told him, Folke, his name was Folke at the time, which is Volker in German. Folke, do you believe in Father Christmas? Right. And that's how it started. So at the end of the day, I have patients sometimes in clinic in London or even here, but mostly in London, who come with the prints from Google about fantastic things. Mm-hmm. And say, number one, what you see on the internet is the glamour.
Yeah.
You don't see the reality. It's not like this. It's not true. But this is from a good center in America. So what? Sure. I mean, So, and then you start to read the literature and to scrutinize what is published. And you see very good papers, you see very honest papers, and you see a lot of rubbish and a lot of ignorance and a lot of bias. And the publication bias is something in our field that is very important to understand. How many papers have you seen showing bad results of DBS, for example?
There are a few, I agree. Yeah, of course.
Why? Don't you have bad patients?
Of course.
I remember when my wife was doing her PhD, she's occupational therapist. And she did a PhD on patients. Some of them were not even my patients. And she had always the UPDRS mean, standard deviation, and range. Well, if you look at the range, there must be a patient who has 100 post-op, who had 80 before. Yeah. So, a group of patients, some of them have got worse.
Worse, yeah.
Don't see them. You don't see them if you look at only the mean and the standard deviation.
Sure.
So you have 50 patients before, 50 patients after. Of course, 50 are better than the other 50. Yeah. But among these 50, there must mutation will become worse in the UPDRS. And this, Andy, you see in the old literature, in the old Lexell or Leiten or other similar literature, you didn't have UPDRS. You had good or very good, moderate, poor, worse. Yeah. You have worse. So in the Lexell paper on pallidotomy, 81 patients, you see that the last 5 on that, his figure was worse in tremor or rigidity or whatever. So this you don't see anymore today. My patient doesn't want to know what is the group. He doesn't want to know what chances I have to get rid of the tremor. Yeah. 80%. The akinesia, maybe 50%. You know, this you don't find in the literature today, but you found it in the old literature if you read 50s, 60s literature.
What do you think has led to that change? Is it publication stress or is it...
And so-called established, scales. And the scales, especially the motor scale, is still the gold standard, you know. But take the ADL scale, and it's not my work, it's my wife's work again. Yeah. When she did her PhD, she studied the ADL scale of the UPDRS ADL part. And she told me, who the hell has done that? The ADL part of the UPDRS, you have salivation, freezing, falling, tremor, and you have dressing and eating and cutting food, etc. Yeah. And she told me, freezing, is it the activity of daily living?
Yeah.
Salivation is the activity of daily living. Falling is an activity of daily living.
Yeah.
These are symptoms. These are impairment. These are not ADL. But still, a bunch of neurologists in a hotel room in United States with Stanley Fahn and Marsden, etc., have decided that this is the ADL scale. Mm-hmm. Half the items of this are not ADL. And this is from a docent in occupational therapy who told me that, who happened to be my wife, but she opened my eyes. Mm-hmm. You know, this is not ADL. What?
No, I agree. Yeah.
Look at it. I mean, go and look at the scale.
Will do. I'll post a link to the website as well. So,
you know, the part 2 of the ADL is half of it is not ADL. You don't salivate every day.
Yeah. So hopefully not. Yeah. So we were talking about the stereotaxy police and how that was for you, and yeah.
It was in a way coming from Lozano. It was I took it very well because he's an old good friend.
Sure.
Although we don't agree on many things, but we are honest with each other. And I think that when he said that, it was in the context of a meeting where I was criticizing some of the publication, among others, the GPI divided by the internal capsule. Yeah. It was not New Orleans. It was in Philadelphia at the American meeting. And then later on, the court jester, which is also a very good thing, because for me, the court jester is somebody who was, as you said, telling the truth without being...
he has the liberty to speak, yeah.
And I think that we need more of court jester. How shall I put it? I would love if, and this is what I tell my students, you have to be critical.
Yeah.
You know, a faith that does not doubt is a faith that is dead. That's how fundamentalists exist. That's how you have ISIS and all these fundamentalists of all kinds. Mm-hmm. They don't doubt what they read. And in science, what is science? Science is curiosity, is to doubt, is to seek, to put into question.
Sure.
Thesis, antithesis, synthesis.
Yeah.
Right? That's what science is. And if you look at the publication, you scrutinize. And the funny thing is that the more big shots authors, or rubbish.
Okay. It's people sometimes say that about Nature papers as well, right?
Most of the retraction are from Nature, Science, New England Journal, Lancet.
Because could also be biased by these papers being more criticized or more recognized, right? In theory, but yeah.
Yes, and also publish or perish, etc. There is a very nice German paper by Donatus. Name is Mental Side Effects of Deep Brain Stimulation for Movement Disorder. The Futility of Denial by Donatus Cyron from Saarbrücken. Karlsruhe.
Karlsruhe, yeah. That's close to where I'm from.
Have you seen that paper?
Donatus Cyron. Yeah, I have it. Yeah, okay.
Fantastic paper.
Okay, that's a good recommendation. So you mean us, especially if there are too many big shots, it's hard to criticize, or
it's hard to criticize, and then you can get problem if you criticize, because then they are editor or they are reviewer, and
sure.
And this is, by the way, also one reason why we in Europe criticize each other much more than they do in the United States. And I have been there maybe 20 times in different places, and they tell me if you have to be careful, because they can stop your grant, they can stop your research, they can have connection.
Okay.
So in the American colleagues very rarely criticize each other.
Okay.
Very rarely. It's not in Europe we can criticize, but we're still friends. We still can talk. We still can.
Yeah.
I mean, the only one who was upset when I criticized him was not you, actually. It was Volker Koenen. But Volker is special also. His baby is the medial forebrain bundle,
sure.
which has been described by no less than
Robert Heath. You mentioned, right?
Robert Heath, already in the 50s.
Yeah. True. I mean, there is also the rat literature of the MFB, right?
Newman. I mean, it was a Newman. He was working on people. But I think it's healthy to have these controversies. It's healthy to have controversies. It's healthy to discuss. I remember a controversy of pallidotomy versus STN DBS, which was, quite healthy, with Maylon DeLong arguing for pallidotomy and Benabid arguing for STN DBS, with pro and con. And this was published in the newsletter of the Movement Disorder Society.
Yeah.
It was a nice discussion.
I totally agree, and that's what I admire so much about that, about the role of a court jester, because I think the easier way would always be to agree with everything and be friends with everybody, but it takes courage and strength to, go step forward, say something, put your head in the, so I really admire that, and I agree with you that's what I meant when, if you ever retire completely, we will I think miss you dearly. And so let's talk a bit maybe more about your work or your own work. Would you have any stories of academic or also clinical success or surprise that you would like to share? Something where you really think this was a surprising turn of events, or this was a eureka moment where you finally understood something, or some anecdote of your long... My main thing, I mean, there are two things that I have published recently about is the ethics of DBS, especially in undeveloped countries. Mm-hmm. And this, I had discussion with Jens Folkman about it, and etc. There are two things. One is what do we do with the brain or with the patient when we treat for dystonia with DBS or SCN DBS for Parkinson? These are the main two. Yeah.
What are the risks of the rebound? What does it mean in terms of being prepared to take care of that patient, of transforming chronic disease into emergency condition where you have to go to hospital on Sunday evening to take care of a patient, like I have published in one of my patients. Others have been at midnight, etc. And this has to be clear to patients in the developing world.
Sure.
Because in Germany or Sweden or England don't care. But somebody who has paid a lot of money, and this has been published, by the way, in India, where patient is admitted with severe Parkinsonian crisis, fever, almost rhabdomyolysis, etc., and medication is not working. The receptors are not cooking. And it is said in that paper, in Movement Disorder Journal, the patient had no money to pay for a new stimulator.
Oh, wow.
Not to mention apomorphine and duodopa, which is outside. So when we consent patients, when I consent patients, I tell them this is once DBS, always DBS, especially SCN. And I have published a paper with that title, once DBS, always DBS. Yeah. I have yet to find the patient who, even if they have a very little benefit, they want a new battery. Even if they have a stroke, they want a new battery for the other side. It happened to one of our patients in London. Yeah. So this, for you in Germany and me in Sweden, is not a problem.
Sure.
But for somebody in India or Lebanon or some other places, it can be a problem.
Sure.
This combined with the fact that Medtronic has decreased the capacity of their PC compared to the Kinetra. Yeah. And this is published by 7 centers, 2 of them in Germany, Grenoble, Israel, Seoul in Korea. About 1/3 to 1/2 of the battery capacity. The Kinetra could...
Oh, it's that much?
Yes.
I didn't know that, yeah.
The Kinetra could last 6, 7, 8 years. The PC, 3, 4 years.
Why is that? Is it really, I mean, it's a bit smaller, but you're saying this is probably deliberate.
There are 8 publications from different big centers. Kiel, Berlin has published that. Tel Aviv, Grenoble, Clermont-Ferrand,
sure.
Etc. And this is regardless of having interleaving or not interleaving or this or that. The battery capacity is less. And this is something that is, if not criminal, at least very bad from the company. And I have published 2 editorials about this issue. Yeah. One with Zelma Kish from Calgary in Canada, that the patient should be informed about this. Actually, in Calgary, Zelma Kish wanted to inform the regulatory authorities, that means the government, about this. And not everybody can have a rechargeable, as you know.
Sure, yeah.
So this is an issue that is very important ethically when you consent a patient. Mm-hmm. Number 1, once DBS or DBS. Number 2, you need a new battery if you don't have a rechargeable. And even rechargeable, suddenly it was 15 years. Yesterday it was 9 years.
Sure, yeah, no, I agree. The rechargeable, that from every laptop, that the battery at some point won't last that long anymore, right? And I really remember vividly your talk you gave in Würzburg about, I think, emergencies in stereotactic surgery. That was a great talk. So I can only imagine that if you fly to Europe to get a DBS surgery, then are back in your home country and something happens, it can really go wrong.
Can go wrong, and I know of patients, it's never published. I know one patient, and I have heard from a very good neurologist in Germany who told me about a patient who was operated from Slovenia or Croatia, who suicided rather than ask the neighbors and the family to give him more money for a new battery.
Wow.
So he preferred to suicide. And this, I cannot tell you who the neurologist is, but it is a German, very well-known German neurologist who told me that.
Sure.
I have other examples, and it's also published now of people who cannot afford to have this.
Yeah.
So you make the patient, in a way, more or less addicted.
Yeah.
To DBS, especially at the DBS. And for the dystonia, the other thing is that people have died, including in Germany and other places, France, and Iran is published from Iran, dystonic storm, which can be, you cannot give dopa, you cannot give anything. Dystonic storm and the patient dies.
You can do surgery right now. Yeah.
We have had a unilateral pallidotomy that saved the life, and this is also published. Mm. And I have 2 patients myself where did pallidotomy because the patient had septicemia, could not have, they cannot put a new DBS, they're infected.
Sure, okay.
The whole patient is infected. But you do a pallidotomy, and you reverse, you block this dystonic storm with unilateral pallidotomy. And since then, it's published from several places. And I asked one colleague in Iran who published this case report, one of the case reports, why didn't you do pallidotomy? He said, we don't know how to do it.
Ah, okay.
And it's dying. You know how to do DBS. Why don't you do a pallidotomy where your DBS was?
Mm-hmm.
And since then, there have been several cases from Italy and other places where a unilateral pallidotomy could reverse the dystonic or even Parkinsonian storm.
Yeah.
And this is something that also ethically has become problematic, where young neurosurgeons don't know how to do a pallidotomy.
Sure, makes sense. Yeah.
So this is my things that I remember. So number one is that we transform a chronic disease into an emergency disease.
Yeah.
And we need to have a standby team, like it's an aneurysm, subarachnoid hemorrhage or something, that you have to rush to the hospital and take care of the patient.
Yeah.
And number two is that you hook patient to a device that costs a lot of money and that sometimes in some countries they cannot afford to pay.
Sure. So would you think lesions would be the alternative then, or better suited?
I think, lesions still have a place. Yeah. Unilateral, better than nothing. Number two, in patients where DBS has failed or you cannot do DBS. And now why lesions are coming back is because of the hysterical push of focused ultrasound that you don't open the brain. In the beginning, they called it non-invasive. And I told the company, because they were don't say non-invasive, you are burning the brain.
Sure. Yeah.
Like when you were a child, you were burning with a magnifier.
I did that, yeah, of course.
Yeah. So now they call it incisionless.
Incisionless, yeah. More true, but...
Well, it's okay, but I mean, what's the problem with a regular electrode that goes with how many people have died of a regular electrode? Provided you don't use a sieve, a sieve.
Yeah, sure. Yeah. So, I mean, I could imagine, at least for some patients, that if you're old and you cannot take a long surgery, and even myself, if I had the choice between DBS and focused ultrasound of an experienced team, it's a one-fit procedure. You go home the same day. You don't carry electrodes or electronics in your body the whole life and so on. So I would probably choose DBS, of course, but it wouldn't be a very easy decision, to be honest.
It depends on the symptoms. If you have bilateral symptoms, if you have on-off and the whole thing, I personally would choose bilateral SCN DBS by a good team that can do that, of course.
Sure.
But I would not choose bilateral SCN DBS if I have a unilateral, I'm 70 and have a disturbing unilateral tremor.
Yeah. I
I wouldn't choose bilateral SCN DBS. No.
Yeah, sure.
I think I wrote a paper a long time ago called symptomatic treatment or surgical treatment. So you are treating symptoms, not the disease.
Sure.
So the patient's problem is mainly dyskinesia the whole day. Okay, I do a pallidal surgery.
Yeah.
Pallidotomy or pallidal DBS. Tremor mainly, VIM or zona incerta.
Yeah.
And I think we have to keep in mind that there is the interest, the science, the nucleus that is very interesting. Things happen. In the SCN, things happen.
Yeah, true. No. Good words.
In the pallidum, nothing happened except the dyskinesia are gone and partly the tremor, etc. In the VIM, the most boring target. Very boring. Nothing happened. So SCN, things happen.
Yeah.
And this, I think there's a bias here.
Sure. So we've talked about successes, but just out of curiosity, is there something where you think this was, a waste of my time, or this did not work at all, or this was a failure even, or something that because that's something good to hear from successful people like you, that the things where things sometimes went wrong. Do you have any story to share in that?
Of course, I I regret to have operated some patients in the beginning because I was too enthusiastic and reading the fantastic literature, etc.
Okay.
And I told you, one of them is published.
Yeah.
I can send you that paper too, and it was really eye-opening, and I'm against very early STEAM. And I wrote, I think in the Lancet, a commentary to the early STEAM study.
Yeah.
Early STEAM done in Kiel and in Salpêtrière, maybe.
Okay.
But early STEAM done in Beirut or Beirut, I think it's completely different. Mm-hmm. STEAM is when the patient needs the STEAM. I mean, when the patient has problem, it's not the duration of disease. It's an example, a guy working in the bank office who cannot sign the papers.
Yeah.
With the duration of disease of 3 years and too much L-DOPA, he gets a little crazy. So of course we do DBS for that.
Yeah.
Don't care about 3 years the duration or not. At the same time, 20 years of disease and the patient doing well with medication and slightly dyskinesia that bother only his wife. I tell the wife, don't look at him. He's not bothered by the dyskinesia.
Yeah, I agree.
You know, he looks like somebody who wants to pee. You know, when you want to pee, you're a little bit...
Yeah, I know that. I even know, the wife thing. Yeah, agreed. I've seen that.
So I'm not operating for the wife. I'm operating the patient symptom that
agreed.
Impinge on his quality of life.
Yeah.
Or her quality of life. So it's a symptomatic treatment, and I have great respect for the brain. So ultra early DBS, like this crazy guy from Vanderbilt University, who operated patient who has 6 months of disease.
Oh, wow.
How do you know it's from disease? Yeah, it's published, and I published a letter to the editor.
Mm-hmm.
You know,
there's the police again. Yeah, that's great. No, I agree. Yeah.
He had 15 patients. One of them got a big infection. He had to take it out. The other had an infarct in the basal ganglia. Okay. Somebody who didn't need an operation in the first place had an infarct in the basal ganglia.
Yeah,
and it's
tough.
1 out of 15 patients. I said, this is criminal. And this is a neurologist, by the way, who is promoting that.
Okay.
His name is Charles. He was in Grenoble a long time ago.
Okay. I mean, you know, the only... So if I was just wondering myself, again, if I were a patient, would I want to get the operation with 60 or with 80 or 75? Then just based on, you know, my general status and cardiopulmonary reserve and so on, getting it earlier since it's a long procedure could also be beneficial despite all the other discussions. What do you think about that? I mean,
it depends. I mean, it's not only age. Of course, it's the general condition, it's the heart, it's the atrophy in the brain, etc. What I'm saying is that early STEAM in general, it has to be something that is purposeful for the patient. Tell somebody who is 60, you can wait, we can follow you. We can see you once every half year and follow you. You can do an MRI once a year and we will operate on you before you get these things. But to operate now, for me, DBS is not prophylactic.
Sure.
It's not prophylactic.
Yeah, I agree. Yeah.
So, and if you're doing well with medication, because often what they tell you is that, my neighbor has been operated, is doing fine, fantastic.
Yeah.
Well, when was your neighbor operated? 1 year ago. Well, wait 5 years. Mm-hmm. If he has freezing of gait, you know, this one of the problems. Let's see how speech, freezing of gait, all these things that we know today that SCN DBS can induce.
Can induce and also cannot cure or cannot ameliorate, right? So we cannot do much about freezing.
So these are things that we have to take into consideration. I usually see patients several times before deciding on surgery. And they said that, and several of my patients have had pallidotomy before, in Sweden at least, and then went on to DBS. Well, because they had new symptoms, they had the gait problems, they had the other side, they had new things, and I don't want to do bilateral pallidotomy, so I do DBS.
Is the reason I wanted to ask that earlier that you don't want to do bilateral, would that be because of side effects, right? Because or why do people scare away from bilateral lesions?
The main issue with bilateral lesion in the basal ganglia and thalamus is speech.
Speech, okay.
So even with DBS, you have speech problem.
Yeah.
You have speech problem bilateral in the VIM, you have speech problem bilateral in the SCN. So if you do a lesion, I have done bilateral pallidotomy, but at least half a year between the two, and provided the patient has no side effect at all after the first pallidotomy.
Sure, okay.
I have done the second. And the second usually is less efficient because it's usually, I make it smaller.
Yeah.
Not to infringe on. I've never had a pseudobulbar problem.
Yeah.
Swallowing, dangerous things. But I noticed that there is a side effect in dysarthria, which can be reversible if you manipulate the current in DBS, but which is not reversible when you do bilateral.
Yeah.
So I think that I have a patient operated 4 times. Thalamotomy one side, then thalamic DBS on the other side, then pallidotomy on one side, then pallidal DBS on the other side.
Yeah.
Between the age of 70, if I remember well, and 78.
Okay.
4 operations.
Wow.
Go after the symptom. That was long time ago, before STN DBS.
Yeah.
Tremor, okay, this. Tremor here, okay. This guy needs this, or this guy needs this. So,
it sounds a bit like hunting, each time, okay, we put another patch on that and so on. Yeah, but
it's symptomatic.
Sure, yeah. So, last final 2 questions. So, when you retired from being the Edmund G. Safra Chair in Functional Neurosurgery at the Institute of Neurology at UCL in 2012, I know that you have trained and inspired at least 2 functional neurosurgeons directly in London that are well known in the field themselves. That's, of course, Ludwig Rinzo and Harith Akram, which I both like a lot. So do you think the 2 will be able to run things there alone? Or is there anything you would like to share about your relationship with them or being a mentor? Did mentoring give something back? Yeah.
This is my best legacy.
These 2 people.
We have trained many people, but me personally, Ludwig was and is an extremely competent surgeon and very driven and works too much and too hard and publish and I'm afraid for his health.
That's saying you who only worked in London in these 16 years, right? So that's the typical mentoring thing.
Fantastic. No, I am very happy that it's Ludwig. And then came Harith, who is a bright guy. I mean,
he is, yeah.
Harith, I have learned a lot of him. Have you seen his thesis about...
I did, yeah, I did. It has a beautiful cover and great content as well. Yeah,
I have to read it several times, and I have to tell him that every time I read it, I understand one more word.
Interesting.
He knows the radiology, he knows the imaging, he knows tractography, he knows the basics, and I have learned very much from him.
He has built a computer himself, a GPU cluster in his office, apparently, Gilgamesh, right? So he built that himself. So he's amazing, I agree.
Harith is fantastic. Harith is a very research-driven, and he is also in the field. He is at the right time, at the right place, which you are also in. And I know that you... Actually, he told me about you first time I met you. That was in Würzburg. Yeah. And he told me, you have to meet Andreas Horn.
Oh, that's so nice. Oh, I'm honored.
And then I met that and we had a brief chat. That was in Würzburg, I remember that. And he kept talking about your work and his work and the many things. And I think this is the bringing, again, imaging the next step.
Yeah.
One day when you can fuse a nice structural imaging where you see, let's say, the STN with a tract going from there to the motor cortex and then say, put your electrode exactly there in stereotactic space. Yeah. You know what I mean? With the frame on.
Sure.
That would be fantastic.
I think that's the goal, yeah.
And verify then that it is right into that tract.
Yeah.
Then evaluate the patient motor-wise and cognition-wise and psychology, and see if you can have a pure motor effect without anything else.
You mean you could even picture in theory having side effect tracts and then avoiding them, right? I think that's our main
I hope so. And your work about group level, your latest paper that you published a few days ago, the paper that comes...
Yeah, the in your image, yeah.
With a group level.
Yeah.
That's good for analysis in group level.
I agree, it's useless for the individual patient.
Exactly. You say the limitation in the paper, you write about the limitation that the fusion error and
Sure.
and also for the individual patient.
Sure.
And our philosophy has been individual patients to analyze it. And I had critique to Hariz sometime using the MNI. The MNI brain is a healthy young brain.
True.
It's not a patient brain.
There is, to be honest, there is an MNI brain of Parkinson's disease patients that was specifically built for surgery by the MNI. I think it hasn't been used that much, but yeah.
An MNI brain of a secondary dystonia patient, MNI brain of a DYT1.
Exactly. That I agree. It makes it less transferable. Yeah, that is a wide topic, and I agree there are a lot of limitations that, as you mentioned.
Why not instead do a template of the patients themselves? Put their brains together and make a template of them, and forget the MNI brain.
So if you want to ask me, so I totally agree that is something people do in the fMRI literature to create an average brain of your cohort of say 20 patients, and that has been shown to be more precise. I think the only downside would be that it's a bit less transferable worldwide, right? So if other people want to compare it, that is what I see as a big strength of the MNI, even with these limitations. It's a bit like the Schaltenbrand. Everybody has a copy. Everybody could say this is where the London group put their things. But I totally see the limitations, and I agree.
What is the laterality of the VIM, the average VIM in Europe?
You think it's different than? Of course, it's different than in Asia or so.
In Europe, it's 13 to 15 millimeter.
Yeah.
In Japan, it's 18, 19 millimeter.
Okay.
The Japanese head is...
You're right. You're right. I mean, coordinates, I agree with you. Yeah. Coordinates are also useless in the individual patient. It's more about what I really see. It's a bit of a very well characterized space that everybody has access to. But again, I see the limitations, and we try to also show individual patients, of course. And so last question, are there topics that you think are important that we did not cover so far? What other things would you like to pass to a younger generation? Because I guess most of our listeners will be, the younger, my age maybe. What should they hear?
I think younger generation should do like Lexell said many, many years ago. Read more, publish less. Sure. And publish more about the important issues. And read critically. Yeah. And read also literature older than 3 or 4 years.
Yeah, I agree. From my point of view, it's tough, right? To read, to get a good overview quickly, or even if you have time, right? To dive into it if you haven't lived through these years. In fact, this podcast is my attempt to try, to pick brains of people that lived through these years that could help us, sharpen our minds or give us some insight about that, because it's really tough if you haven't been there to then read about it and learn it all from yourself. So,
the main thing, if you compare with the old literature, which was fantastic. I mean, I have read the books of Munninger and Richard, these autopsy books and other books, and paper and Spiegel and Weiss's and all these things. And I will send you also the Journal of Neurosurgery reference, where you have this fantastic debate that you can read. Mm-hmm. Yeah. Everybody what they did. If you compare to what we're doing today and what is happening today, basically it's very little new. Agreed. Very little new. Many things have been described. Even the CG25, I told you, was described, and the lesion was there. The main new things that has happened, the main advancement in neurosurgery, including functional neurosurgery, is not micro-recording. It's not the tracts. It's not the physiology. It's not the circuitry. They knew about the circuitry. The circuitry was described by Spiegel and Weisses. That's why they did dorsomedial thalamotomy in the first psychosurgery.
It was even described by the Vogts in the 1920s, right? So
yeah, who had the brain of Lenin.
Yeah, it's true.
So, okay. The main advance in neurosurgery, including functional neurosurgery, is imaging. Imaging. MRI, structural, the functional, now tractography. You guys, your work is the main advance bringing the field forward. Micro-recording happened before. Telepotomy, DBS happened before.
Sure.
The first DBS was psychiatry in the 50s.
Yeah.
You know, DBS was done before Benabi.
Of course, yeah, with the Heath era. Yeah, I agree. Yeah.
So the main advance today that make me happy as a neurosurgeon is I can see into that brain and I can see what I have done there.
Isn't that amazing? I agree. Yeah.
So imaging, to ask a neurosurgeon, you can see before you operate a tumor or whatever, a bleeding, you see exactly what it is. You see, and you can take away the tumor and do an MRI. Oh, there is still tumor there, or oh, it's no more tumor in the brain. You know, it's imaging. You see.
Agreed.
And to finish, I will tell you, we have 12 cranial nerves.
True.
Right? 12 pairs.
Yeah.
How many go to the eye? 7. 7 go to the eye. Look at them. You know, including the vapors, including the facial nerve, including the oculomotor, and the last thing I want to say, which cranial nerve occupies in the brain the biggest area? I have the optic nerve, the chiasm, the optic tract, the radiatio, all the way in the temporal lobe and back to the fissura calcarina. Now, this cranial nerve, people don't use it. They don't look.
I got you. Okay.
The biggest nerve of the cranial nerve is the optic nerve in the brain. And 7 out of 12 cranial nerve go to the eye.
Sure.
And it's muscles and it's, you know.
You're making the point that people don't look and that you had a great story to that. So I get that now. Okay.
And imaging is what? What is imaging? Is looking.
Yeah, sure.
You look.
Putting light into...
You do your tractography and you look, where does it go?
Sure.
So my legacy, or not legacy, my message to younger people is read more, write less, be critical, and look and understand what you look at.
Marwan, thank you so much. This was really amazing. Great last words for the interview. So thank you so much for being a part of this and taking the time.
Thank you, me. I am very honored to have been chosen by you to be on this.
Not at all. No.
I would love to look at the other people who, at the results, so to speak, in the future.
Great. Yeah, I hope there will be many more. Let's see how it goes and how people react to it. Yeah, thank you so much for that.
Thank you for listening to Stimulating Brains.